All of us have some kind of a journey when it comes to doing what we do and why we do what we do. And just wanted to share a little bit about myself and how we sort of got to where we are today. Have pretty humble beginnings. I went to med school in India in a very wonderful, simple government medical college in northern India. Came to the States, did residency at UCLA, was very lucky to match in a wonderful internal medicine program. And after that, I worked as an internist for a few years in the hospital setting, after which I got interested in pulmonary and critical care medicine. And it wasn't until pulmonary medicine where I was sort of enlightened about what sleep medicine is and how broken the system actually is when it comes to like how do you deliver a multidisciplinary care to patients that is focused around outcomes. With that mindset, the folks at Harvard took me in as a fellow and got to do fellowship with even more intelligent people. And ever since then, the intention has always been how do we deliver Harvard grade sleep care online from a sleep first standpoint, and in the process of doing so, also taking care of all of the other sleep disorders. As you guys are all aware, during the pandemic, it changed how we started taking care for other humans and family members. And Empower Sleep was sort of born out of this idea of how do you deliver sleep care online during that pandemic. And it sort of continued to evolve ever since then. And I think a lot of the providers here are probably aware of this quote or have heard it at some point in time, but I'll just read it out because I think it highlights such an important function or purpose that I think when shared with your patients that you're seeing in clinic or in your practice, it gets the message across. If sleep does not serve an absolutely vital function, then it's the biggest mistake the evolutionary process has ever made. And that's really powerful because, sleeping is when we sleep from an evolutionary standpoint, we expose ourselves to risk of like tribes invading our town or our home. It's the most vulnerable state that our body is in for 8 hour time. And we know that evolution doesn't make mistakes. And so if evolution has caused us to sleep and for us to sleep in a consolidated fashion for 8 hours, unlike mice, which are snacking on sleep across a 24-hour period, there has to be a very strong reason why our bodies do this. And if we break this, if it breaks, why it leads to the consequences it leads to. And that sort of like takes me into this idea of like what happens during sleep. And for most people who have an untrained eye, they may say that this is a parked car or a Tesla. But for somebody who has some idea of what's going on, they can see that this car is being charged. And that's something that we are aware of. But if I told you that during this time of quote unquote charging, not only is the battery getting charged, but the wheels are getting a new layer of rubber, the brake disc fluid is getting exchanged, the car is getting a vacuum, the windshield wiper is getting cleansed, the paint is getting a new coating on top of it. That's exactly what happens during sleep. Sleep is not just a function of charging of the brain or of the body, but rather there's a whole host of physiologic processes that happen during sleep. And it's not like the body is parked or resting, but rather when the body is sleeping, there's a whole host of physiologic processes that are happening. And when us as providers are taking care of these patients, the goal is really how do you restore that physiology? How do you restore these functions to be able to happen back again? And these are my two children, and now we have a third one. But when they're sleeping, something like this is actually happening, where not only is the brain resting, but rather their body on a physiologic level is recharging, and a whole host of physiologic processes are happening. So with that being said, we'll talk a little bit about why sleep is so important, why you are so important as a clinician in your patient's sleep journey, and lastly, how we can support you. So a lot of the functions of sleep are sort of nebulous. We all kind of have an idea, but over the last decade, I think we've developed a lot more clarity on what happens when we sleep. And one of the most important functions is there is a restoration of the brain and body that happens. And I'll show you a picture about that. During sleep, the brain is filtered of waste materials, specifically adenosine, which makes us sleepy, as well as beta amyloid plaques, which are a precursor to Alzheimer's disease. So when people are sleeping, the brain is being filtered of these toxins that build up during the day that hopefully can prevent these downstream consequences of brain dysfunction, such as cognitive impairment and dementia. Other functions of sleep are to conserve energy. A very important function of sleep is to consolidate memory and reinforce memory. So if you take a group of people, and this has been studied numerous times, but the idea is that if you take a group of people, you allow that half of that group to sleep 8 hours, and you allow the other half to sleep 4 hours. And the day prior, if you have taught them some new task, the people who slept less, they will recall almost 50% less of what they were taught the day prior. So sleep plays an extremely important role in the consolidation of memories. And this is most important in I think, children who are in school, in high school, elementary school, or any advanced degrees, who are trying to learn new things. And sleep, this idea of pulling all-nighters, it just doesn't work. It's not conducive to learning new things. We know that sleep serves a function in our immunity. People who have chronic sleep deprivation, they get sick more often than people who sleep well most of the time. And we saw that actually very clearly during COVID. People who had obstructive sleep apnea, mortality was much higher in that population as compared to people who did not have obstructive sleep apnea. Other functions that happen during sleep is for growth and restoration, and I'll show you a diagram. But growth hormone, which is critical for protein synthesis, only peaks during sleep. It has circadian properties, and it only happens during sleep. So a lot of these important hormones are only secreted during sleep as well. And there's a lot of other things about sleep that we have an idea of, but we don't completely understand. Here's a diagram showing how CSF, how blood coming through the dural matter, coming into the brain, flowing through these aquaporin channels, it filters all of the toxins that build up in the brain. And this system is called the glymphatic system. And it's because of this system that adenosine is filtered. It's because of this system that the beta amyloid plaques are filtered. And the interesting thing is that during sleep, during specifically deep sleep or stable sleep that we see on these sleep tests, is where cerebral blood flow is at its peak. So just sort of highlighting how important stable sleep is. Other things that happen during sleep are body temperature drops. It plays a role in energy conservation. Urine volume drops during sleep. Blood pressure dips during sleep. This is a very important reason why we always look at what's happening to someone's heart rate during sleep and what's happening to blood pressure during sleep, because non-dipping of heart rate and blood pressure is predisposing to developing hypertension or any cardiovascular or neurologic disease in the future. During sleep, melatonin levels physiologically rise. During sleep, thyroid hormone levels they rise, and again during sleep, growth hormone levels they rise. So sleep is not just sort of a resting body, but rather a whole host of physiologic processes that are happening. And the other thing that is extremely important is we all know that there are like stages of sleep, REM sleep and non-REM sleep, but the thing to be mindful of is that the distribution of these stages with each cycle of REM, non-REM, and awake is different in the earlier half of the night as compared to the latter half of the night. So in the earlier half of the night, each of these cycles are predominated by deep sleep or stable sleep or N3 sleep. But as we go later and later into the night, or earlier and earlier into the morning, there is more and more REM sleep. So the reason this is important, REM sleep plays a very strong role in memory consolidation and emotional stability. So people who are chronically sleep deprived, they are losing disproportionately more REM sleep than they are non-REM sleep, which may be a reason why people who are chronically sleep deprived don't make good emotional decisions. And also in children, when they don't get enough sleep, they're doing okay on their REM sleep, but they're disproportionately lower on REM sleep, which is critical for learning and emotional stability. So a little bit, we're all seeing patients. I think as a sleep provider, patients come to us knowing that they have a sleep problem. But as a primary care physician, as a dentist, as a neurologist, as a cardiologist, you have the opportunity and the privilege to make a difference in their life. And by helping these patients identify a problem sooner rather than later, you have the opportunity to prevent a lot of short-term and long-term consequences. And this is just an example of when there is sleep disruption on a physiologic mechanism, what are all the different things that are happening, resulting in both short-term and long-term consequences. So when there's sleep disruption, there's a lot of catecholamine disruption, usually higher levels of catecholamine because of a higher sympathetic state, higher cortisol levels. This results in stress, somatic problems, psychosocial issues, as well as the development of cardiovascular disease and just a much higher heightened inflammatory state. With circadian disruption, again, it results in both short-term consequences and long-term consequences. With sleep disruption, there is a reduction in the sensitivity of insulin. Thereby, the other way to think about it, there's more insulin resistance with sleep disruption than there is without sleep disruption. The other thing that happens, leptin and ghrelin are hormones that control our appetite. When these are dysregulated, satiety is not well controlled, and there's a tendency to eat more. So patients who have obstructive sleep apnea, they unintentionally have a more carbohydrate-rich diet as compared to patients who don't have obstructive sleep apnea. And then that leads them to go down this like downward spiral of obesity and worsening of obstructive sleep apnea, leading to a lot of these downstream long-term consequences with obesity, diabetes. Also with sleep disruption, there's increased oxygen consumption and CO2 production, and we know that's not healthy for the brain or the heart. Sleep apnea by itself or any sleep disruption is a pro-inflammatory state because of these rise in interleukins and cytokines and C-reactive protein and reactive oxygen species, resulting in a lot of the long-term consequences. And melatonin, there is some idea that melatonin or circadian disruption, it may have some like cancer protective properties. So this data actually comes out from, it was a women's nursing cohort. I think it's, don't quote me, but I think the Wisconsin cohort. And what they identified was nurses who are shift workers. There is a higher incidence of breast cancer in that population than there is in other women, suggesting that then that was sort of the reason why shift working is now considered a carcinogen, which we did not know before that. And we think that that stems from circadian disruption as well as the disruption of melatonin. One of the most important things, and what we are always trying to prevent in patients, is the development of cardiovascular disease or brain disease. And this is a really nice, well-published article talking about the pathophysiology of how specifically obstructive sleep apnea results in all of these downstream cardiovascular comorbidities. Sleep apnea, these repetitive pauses in breathing, result in hypoxia as well. So like we use the term intermittent hypoxia with reoxygenation. It results in sympathetic stimuli, thereby this autonomic dysfunction. There are more arousals and disruption of deep sleep. In addition to that, so if somebody is breathing against a closed epiglottis, there is increase in intrathoracic pressure. So these intrathoracic pressure changes are putting stress on the cardiovascular system, as well as even causing sometimes reflux disease. And the absence of breathing results in a rise in CO2 levels, which result in hypercapnia. All of these consequences of apneic events result in all of these downstream mechanisms that result in the downstream cardiovascular diseases. So inflammation happens because of all of these. Endothelial dysfunction. If there's endothelial dysfunction, there's going to be platelet aggregation and hypercoagulability. There's metabolic dysregulation, especially at the level of the pancreas. There are these hemodynamic changes that happen because of the changes in intrathoracic pressure. This leads in left atrial enlargement. Left atrial enlargement is a precursor to develop atrial fibrillation, and then all of this sympathetic activation. So just by having these obstructive events, you can now start seeing like these are all of the downstream pathophysiologic consequences. And as a result of that, these patients are now developing hypertension, AFib, and other arrhythmias. These are all precursors to developing heart failure, coronary artery disease, stroke, pulmonary hypertension, diabetes, and unfortunately like a higher mortality. So you're in this position to identify obstructive sleep apnea and thereby hopefully prevent these downstream consequences of obstructive sleep apnea. And we all need to collaborate. Sleep is something that is common to all human beings, all species. There is not a single species that doesn't sleep. Even birds, when they don't sleep like we do, but half the brain sleeps while they're flying, and then the other half of the brain sleeps. So they continue to go. So we all sleep at some point in time in some fashion. In humans, sleep care is a little bit fragmented, and all of us really need to come together while keeping the patient in the center. And be able to deliver like this multidisciplinary care. And I like this picture a lot because it sort of puts the patient as the pilot or in the driver's seat, And all of us are basically doing our part so that this vehicle, which is the human body, can do what it needs to do and perform. And with how do we develop these collaborative efforts? It is a little bit challenging, but we are all making progress in doing this. But it starts with like knowing your sleep physicians, knowing the primary care physicians in the community who are seeing these patients, knowing the pediatricians in the community who are seeing the kids, knowing the sleep physicians that you can refer your patients to, knowing the ENTs, physicians, as well as knowing the local sleep programs. Having these relationships and having a clear channel of communication so that patients don't get lost in the process and there are good referral mechanisms in place is all key. And the focus, and specifically what we really try to focus on, is like having very short wait times. If the wait times are very short, patients get seen in a more quick fashion. We really focus on allowing these referrals to be as smooth as possible. When we refer our patients to dental offices, we try to be as clear as possible that this patient is coming to you. They've been seen by a sleep physician. They've had multiple nights of sleep testing done. Now we need your help for an evaluation to see if they're a good candidate for any kind of a dental appliance. And then after that, we hope that these patients can continue to establish a long-term relationship with you so that they have this continuity of care. One of the other things that we really try to focus on and take pride in is personalizing sleep care. We know that as providers, I think we know this more than the medical equipment companies, is that we have to use the right tool and the right patient. Outcomes are good when therapy is personalized and we use the right tool for the right individual, whether that's a dental appliance and then the whole, the plethora of dental appliances, and then also from the PAP standpoint. We know that it's important to educate patients. If they understand why sleep is so important, then there is a completely different buy-in of like why this therapy is going to be so critical for my life and my longevity. One of the other focuses that we have, and when we collaborate with dental offices, that we want these sleep tests to be read in a very seamless fashion, usually within 24 to 48 hours. Our other focus on working with dentists is to provide patients the prescriptions for these oral appliances so that they can be covered from insurance. And we also help coordinate the care between the patient, the dentist, the patient, the ENT physician, the patient, the primary care, so that everybody is really kept in the loop. You're probably already aware of this, but even the American Academy of Sleep Medicine recommends that to consider oral appliance therapy for patients who have obstructive sleep apnea and or snoring over no therapy. And just reading it out loud, we recommend that sleep physicians consider prescriptions of oral appliances rather than no treatment for adult patients with obstructive sleep apnea who are intolerant to CPAP or prefer an alternate therapy. So there's a ton of evidence out there that supports that dental appliances are useful, they should be used, and they should strongly be considered in patients who have obstructive sleep apnea. And this has been the idea of doing a multidisciplinary approach for patients and having good outcomes has been very well published and has been repeated over and over. At Empower Sleep, we just try to do this in a virtual medium so that patients can have access to their sleep physician, their dentist, an ENT physician, and all of the care is very seamlessly coordinated. It would require a little bit more information, but getting some idea around sleep timings is critical. When patients say that I cannot fall asleep, but when I do fall asleep, I can sleep for a very long period of time, that makes me think of some degree of sleep onset insomnia, like they're not able to fall asleep quickly, but once they do, they can stay asleep. Like the more common reason for that is something like a circadian rhythm disorder, like where their body clock is a little bit delayed. So getting some idea on what time they go to bed and what time they wake up gives us some insight. And to get even more details, it's always a good idea to ask, like, on the weekends, what time do you go to bed and what time do you wake up? Because, people who have delayed sleep phase, they may get into bed, say 10, because that's what's socially acceptable. They can't fall asleep until maybe midnight or even later, and then they have to wake up at 5 or 6 a.m. and then they're sleep deprived on the weekends, and then on the weekdays, they're sleep deprived on the weekdays and then sleeping in and catching up on sleep on the weekends. So like delayed sleep phase is one thing that comes to mind. The other thing that one can do to get a better understanding is have them maintain a sleep diary, because if somebody is sleep deprived for a few chunk of the week and then catching up on sleep on the remaining week, many times patients will only think of the time where they are catching up on sleep, but that is all rebound sleep. So if you look at someone's sleep diary, you can actually then start looking to see that, okay, that the average number of hours slept across 2 weeks is perhaps maybe 8 hours, maybe 9 hours. Then it doesn't feel as pathologic as somebody saying that I need to sleep 12 hours, but that's actually just catching up on sleep, perhaps on the weekends. The other thing that can happen, so like, this idea of like 7 to 9 hours, that comes from population statistics, and people who need more sleep, that's called idiopathic hypersomnia. So that's a central disorder of hypersomnolence, and that could be the underlying problem. It's not very common. Idiopathic hypersomnia is less than a few percent of all people who have excessive daytime sleepiness. Sleep apnea is the predominant reason. People who have idiopathic hypersomnia typically they don't have sleep apnea, they don't have insomnia. Biologically speaking, they just have a longer sleep need, and that can be managed with stimulants during the day. But again, having a sleep test is the first step. And even if somebody is considering idiopathic hypersomnia, they should have an in-lab study followed by what's called an MSLT. That's a nap test during the day, where you give somebody 5 opportunities to take naps during the day, and you measure how quickly do they actually fall asleep. So that would be the way to diagnose it, and the treatment care plan for that is fundamental, is completely different. But a home sleep test is a very good start. It depends on the sleep test, number one, what kind of sleep test you're using. If we're using sleep image, for example, the sensitivities of identifying severe sleep apnea is north of 98%. So it's very sensitive. Because with mild sleep apnea, the sensitivities are in the low 90% range. It becomes a good idea to do multiple nights of testing so that you can see what's happening across multiple nights. The more nights of testing we do, we can increase our sensitivity of not having a false negative test. That is a very common scenario and unfortunate problem. And I think it stems from the idea that the lack of education around the importance of sleep. I think that's number one. Their patients are just not aware of like how important healthy sleep is from like a biologic standpoint. So what we do, I can share with you what we do in clinic when we see patients who have a suspected sleep problem. We've built out like PowerPoint presentations. These are like 15-minute, 20-minute presentations that we do with patients to give them some sense of, okay, like we are suspecting this problem, and this is how this problem ties into all of the things that you are sharing with us. And that seemed, and like many times, either if I'm observing one of our nurse practitioners or if I'm the one who's doing like the presentation, I can get a sense that patients are nodding their head like, okay, yeah, this clearly makes sense. So I think education is key in terms of getting that self-drive that I want to now resolve this problem. That's one thing. And I think the other thing that could be, that I really can't speak from experience, but I think it would be a useful idea, is tying this education into airway rather than tying it into a dental problem. Because of like, I think James Nestor's book and Breathe, and there's just so much more awareness about the importance of healthy breathing than there ever was a decade ago. So tying dentistry into airway, I think, is an interesting strategy that I think could be useful. And like the analogy that comes to mind is, historically, diabetes equaled insulin. That's just because that was the only therapy available. But now that's not the case. You have these gliptins, you have metformin and sulfonylurea, you have all of these different medications. And now it's like, it's foolish to only use unimodal therapy to treat a problem. If you look at hypertension, historically, beta blockers were one of the earlier medications that came out to treat hypertension, but now you have ACE inhibitors, ARBs, and all of these different classes of medication. So I think, and sleep apnea is also a chronic disease like diabetes or hypertension. Sleep apnea, if it's a chronic disease, and now that we have more therapies available, it's extremely important that we get out of the mindset of this or that, but rather this and that. And how do we stack different tools to optimize someone's overall sleep health. It's unfortunate, but it's going to change like in the next 5 to 10 years. So what happened was Medicare created these rules that, you can either get a CPAP or you can get a dental appliance because it fell into this category of like DME, but it's really like a prescription medication to treat a problem. And as we continue to take care of these patients and do multiple nights of testing and really get a good understanding of what is the problem here, we've been very successful at using multimodal approaches to help somebody optimize their sleep. We have patients who are in dental appliances plus CPAP. We have patients who are in dental appliances plus a side sleeping pillow, dental appliances plus Diamox for high loop gain central sleep apnea. With each incremental intervention, the improvement in the quality of sleep continues to go up. So being mindful and being aware that there are a whole bunch of tools that we can use, we should definitely utilize them to their maximal capacity. It's a bit challenging because sleep tests are very non-specific. They are specific in the data that they provide, but they are non-specific on what causes that data to be the way that it is. So for example, fragmentation, like if somebody has anxiety, PTSD, fibromyalgia, chronic pain, chronic insomnia, sleep apnea, restless legs, like the list goes on and on of what causes sleep to be fragmented, because what's happening is the overall threshold for arousal is a lot lower. People who have PTSD have a low arousal threshold. They are easily aroused from sleep. So that by default will cause their sleep to be fragmented. So it's hard to spot that in a sleep test, but the sleep test can tell you that the quality of sleep is poor, fragmentation is high, stable sleep is less, and then that can start the conversation like, hey, what else is going on? Like, how's your mental health? Are you in chronic pain? What else could be going on that could be causing you to have poor quality of sleep? So that's sort of been our approach, but it's not, a sleep test cannot necessarily tell you, especially a home sleep test, what the drive, if there's underlying PTSD or not, unfortunately. Trazodone, it's a antidepressant. It falls into the category of antidepressants, and it has sedating properties. So because of that, we use that as a sedative or a hypnotic for sleep. And trazodone can increase the amount of stable sleep somebody has, and it can work, and it can increase the length of sleep that somebody sleeps. So trazodone is an effective medication. It should be used with caution in elderly because it has anticholinergic properties. So if they have like glaucoma, dry mouth, urinary retention, these are potential adverse effects that one should be aware of. But trazodone does help. It increases the amount of sleep somebody gets, and it also can increase the amount of stable sleep. The beauty of this like multi-night testing is that we can prescribe a medication for a week, have them test their sleep for a week, and then see what happens. So then that really allows us to personalize the care that we're delivering. One thing that could be considered is just referring these patients to a local sleep physician or a virtual sleep physician that you guys are partnering with. Like when you have these patients who you think that there is a problem and you think that a sleep disorder is tying into their dental or airway disorder, what we have found to be very useful and insightful, I guess I should say we, but like what the patients have found to be very useful and insightful is when they have this virtual consultation with somebody else who's going to be also doing the education, then that helps them close the loop that there is something wrong and a sleep test should be done. And nowadays doing a sleep test is so easy that if somebody truly feels like something is wrong with their sleep, it's very unlikely that they don't opt in to do just a couple of nights of sleep testing. I feel like if the patient is suffering, it's like the easiest way to get some data to understand if anything else is wrong or could be driving that.